thank the organizing committee for inviting me to give this talk, and also to acknowledge and thank Professor Frimpong Boateng, who has trained all of us and provided a platform for us to be able to practice cardiac surgery. This is not the end of my talk. Somehow I knew we were going to run into trouble, so I'm telling you the end. So if I get somewhere and we stop, you've heard all the lecture. This is all the lecture is about. 3 points. One is that there are 280,000 infants born in Africa every year with congenital heart disease. So that's the first point this lecture will establish. The second point is that less than 1% of them receive definitive treatment within 1 year. Most die before they reach age 5. And this means that there are urgent policy measures that are required to provide affordable treatment to address this needless childhood mortality. So this is how I'm going to approach it. First, I'm going to look at the burden of pediatric heart disease in Africa. Then I'll look at the access to pediatric cardiac service in Africa in terms of availability and affordability. And then I'll talk about what needs to be done. Pediatric heart disease is either congenital or acquired. The bulk of it is congenital, and so I'm going to focus on congenital heart disease. It is not that rheumatic heart disease is not there. It is there, but its mode is quite difficult to investigate because there are no real data on it. Congenital heart disease presents something that is somehow more easier to handle. By congenital heart disease, we are referring to 3 things. First, it's a gross structural abnormality of the heart or intrathoracic grade vessels. Second, it is present at birth. And third, it has actual or potential functional significance. What is the burden of congenital heart disease in Africa? Most studies tell you there are no real data, there are no population studies in Africa, and that is true. But to be able to advance the practice, we need to actually calculate the burden of disease. So the question I'm looking at is how many children with congenital heart disease are born in Africa annually? Because we don't have any population data, we just have to extrapolate and use hospital data to give us an idea, and that's exactly what I'm going to do. To do that, first we need to establish the incidence of congenital heart disease in most studies is about the same, regardless of race, ethnicity, or social background. And so we can take that as an assumption. So in most studies, you have an incidence of about 0.8 to 1% of live births. So that becomes one of our assumptions. The second thing is to establish the live births in a region or a country. Now, to establish that, we need to know the total live births and then the infant mortality rate. So if you get a difference, you can multiply that with the incidence and you have an idea of the burden of disease in a country. So what I've done is to look at all the 55 countries in Africa, take their population data and work it out and see what we are dealing with. So this is what you get. Not surprisingly, Nigeria, being the most populous nation, comes up with about 47,000 a year born with congenital heart disease. And then you have the other countries coming up, DRC, Ethiopia, Egypt, in that order. Ghana comes up to somewhere in the 11th position with about 5,800 cases every year. So these are new cases that are added to the pool every year. To give you an overview, I've done this map color-coded. So you can see the region where the color is darkest, that's where you have the highest burden. So Nigeria, DRC, and then you have countries like Ethiopia, Egypt coming up, then Kenya, Uganda, Tanzania. Then you have South Africa, Ghana, and the other countries following up. A few countries didn't have data. The Western Sahara, the Canary Islands, there are no data there, so you don't really get anything there. But this gives you an idea of the burden of disease that is present in Africa. Now remember, this is new cases coming every year. As to what is there originally, we don't really have any way of knowing. Now, this is an idea of the regional estimate. So you see on the map there, the various regions, Western Africa, Eastern Africa, Central, Southern, Northern. Certainly, the highest region is Western and Eastern. Unfortunately, these are also the regions that have some of the least resources. That is where the highest burden is. Now, if you look at Africa as a whole, we make up about 1 billion of the world's population now. That's about 14% of the world's population. And yet, we have a total, if you add the figures, it comes to about 278,000 new cases every year. So there's a disproportionate burden if you look at the African continent. We form 14% of the world's population, and yet we have about 27.8% of the world's burden of congenital heart disease every year. Now, so we have an idea of what the burden is annually. It's about roughly 280,000. But what is the access to definitive care on the continent? Now, to do that, we need to find out what percentage of individuals with congenital heart disease in Africa receive definitive surgical care. And then we also need to find out what happens to those who don't get treatment. Data in Africa, again, is difficult to find. So what I've done is to use Ghana as a surrogate. I'll explain to you what that means shortly. Now, access basically defines the potential to command appropriate healthcare resources to preserve or improve health. Most studies look at it in two forms, either in terms of service availability or service utilization. Two major factors affect service utilization. One is the physical or geographical accessibility. And then the next one is affordability. In other words, the service may not be available at all. If it's not available, then you don't have access of any kind. But the service may be there, but if you can't afford it, you still don't have access. So those are the two factors that determine your service utilization. So what I'm looking at next is the availability of service on the continent. Now, I didn't draw this map. This is from a paper that was published by the group in Cape Town. It came out May of this year. But what they've done here is to give an idea of the countries in Africa with established cardiothoracic programs. So this is not pediatric, this is cardiothoracic as a whole. Now, the darker regions are countries with cardiac programs that are performing at least 500 cases a year. So you can see South Africa, Sudan, and Egypt. I don't know how they got their data, but this is what has been published. So these are the three largest centers that you have on the continent doing at least 500 cases a year. Then the lighter areas are programs that are doing somewhere between 100 and 500, anywhere between 100 and 500 cases a year. The areas without any color are supposed to be areas with less than 100 cases a year. So you basically what they've done is to group the countries on the continent into three. The largest centers doing more than 500, the medium ones doing between 100 and 500, and those doing less than 100. Now, clearly, if you look at this, you know we have a big problem on the continent. The service is not available in most places. Again, if you look at the burden, the graph that I showed you earlier on, from the eastern belt all the way to the western belt, you can see the paler areas. So it means that these areas are quite underserved in terms of cardiac surgery. Now, this slide shows you what is happening in Africa compared to the rest of the world. In the US, there are 120 pediatric cardiac centers, and they perform 24,000 congenital heart operations a year. Now, in the US, the burden annually is about 40,000. So they get about 40,000 cases a year. They are able to perform 24,000. This is 24,000 of all ages. Now, a country like Brazil has 60, and they do 9,000 pediatric cardiac operations a year, congenitals. China and India together have 34 centers. They do 66,000. The two largest centers in Africa put together do about 3,500. That's 11 centers together. Now, with that data, I'm not sure if you were to put the whole continent together where we will stand. It's just 3,005 for the two largest centers. And this is pediatric cardiac congenital of all ages, not infants. So this is not really addressing the new cases that are coming. This is pediatric cardiac cases of all ages. Next thing I want to look at is the problem of accessibility. I mean, I think Dr. Shiba was talking about the difficulty of having one heart center in Ghana sitting down south And everybody up north who have a heart problem are having to come all the way down. In some places, if this is the ambulance you are using to transporting units, you can see the problem you have. I'm not sure the Toyota guys will be very happy with this. But these are things that happen on the continent, and it affects Essex seriously. So you can see in Africa we have new cases about 280,000. The two largest centers together are doing about 3,500 cardiac ops a year. We still don't have complete data for the rest of the continent. So what I'm going to do next is to take Ghana, which lies in the middle somewhere, and say probably the situation in Ghana will reflect the average African country. Depending on which country you are looking at, it may be plus or minus. But we have data for Ghana, so we can look at that. Now, I did the birth prevalence for 2010 for Ghana. It comes out to 5,840 new cases for that year. Next, I look at the subsequent year, how many pediatric cardiac cases were done. 818 cases were evaluated at the clinics in all. Median age of 2 years. So half the patients are less than 2 years, the other half is over 2 years. Infants in that group, that is, if we were to look at the 5,800 born the previous year, there were only 329 of them who were evaluated at all. And out of that, I'll show you, this is the spectrum of cases that we're seeing. And you can see from there, VSD, ASD, tetralogy, the three lesions make up about 75% of the cases. Now, I think that the interesting point to note there is that these are lesions that you can cure with one operation. So basically, the bulk of these patients can be cured with just one operation. There are more complex ones, but they are not in the majority. This is the spectrum of operations that were performed for those patients. You can see the modified BT shunts for right ventricular outflow tract obstructive lesions, tetralogy being the largest, and PDA interruption were the largest cases done. Between the two of them, that's about half the number of cases. And then the open heart procedures, VSD closure, correction of tetralogy, ASD, repair of double outlet right ventricles, double chambered, etc., cord triatriatum. So the open heart cases make up about 50% of the total cases that were done. So this is a total of 128 patients, median age of 5 years. Now, if you remember the previous slides, the median age at diagnosis was 2 years. The median age at surgery is 5 years. It gives you an idea of the waiting period. How long do patients have to wait to raise money to come for surgery? So after diagnosis, patients have a substantial length of time waiting to raise funds just to be able to afford surgery. Now, with that in mind, it won't surprise you that only 6 of the infants born the previous year had surgery of any form. So you are looking at a percentage of less than 1%. Now, the operative mortality was 7%. The other issue there was cost. The cost of open heart procedures, about $6,000. If you were to do a closed heart procedure, it was $1,700. Now, that's a factor of about 3. The interesting thing with that is, if you look at the affordability, if you were to drop the cost of the open heart procedure to the same as the closed heart procedure, about 7 times more patients will be able to afford it. So it tells you the huge impact cost makes to availability. So this is a summary of what we find with the access in Ghana. 5.6% of them receive a tertiary level diagnosis. Less than 1% receive a definitive diagnosis. Now, what happens to the rest? The population pyramid gives you an idea. The bulk of the patients are aged 1 to 5 years, which means that these patients are actually dying off before they reach age 5 without any treatment. Now, this graph shows it quite clearly because you can see within the first year, there's a rapid drop-off, and then the 2nd to 5th year is another quick drop-off, and then it levels off from there on. So most of these patients are dying before age 5. What needs to be done for these patients? Not difficult to tell. 1, we need to build infrastructure. 2, we need to train personnel, and then we need to provide affordable treatment. But we've heard, as we heard from previous speakers, the political and public will to do this kind of thing is very important. Now, this summarizes the kind of infrastructure and manpower requirements that are required. Now, these are things you get from guidelines from Europe and America. Now, this is what they are using, and this is what we should be aiming at. Now, one needs to build one such center for 5 million of the population. So in Ghana, roughly what we are looking at is we should have not less than 5 of such centers to be able to do the service that we need. Okay, so basically our strategy for handling this thing is to focus on curable lesions within the first 2 years of life and to commit funding to subsidizing costs to under $2,000. Okay, so we come back to the slide I began with. 280,000 infants born every year in Africa. Less than 1% of them probably receive any definitive treatment, and urgent steps are required to deal with the problem. Thank you.
Thank you very much, Dr. Edwin. You have performed very well in a short time. A lot of information. Thank you very much. The next speaker.